Hi, everyone, and welcome back to this installment of Critical Care Echocardiography, especially for the resource limited and austere medical provider. So we went over some measurements, all taken in the parasternal long axis view, and now we're going to move to parasternal short axis view. To obtain this image, generally take in cardiac mode your probe from facing the right shoulder and rotate it 90 degrees to face the left shoulder. And this will get your probe from the parasternal long axis view to the parasternal short axis view. Where I like to start is at the fish mouth view of the mitral valve, and that's a good point to know where exactly you are in the heart. If you move or fan the probe superiorly, where the probe tail is going inferiorly, you'll get to the aortic valve, and if you fan the other way, then you'll get down to the papillary muscles. And the parasternal short axis view complements the parasternal long axis view by offering cross-sectional slices at multiple levels. So the aortic valve most superiorly, the mitral valve, and then the papillary muscles. And what this does for us is it enables a targeted assessment of valve morphology and motion, regional wall motion abnormalities, and right ventricular size relative to the left ventricle. In emergencies, the PSAX view is particularly helpful for evaluating for right ventricular strain, which may be suggestive of pulmonary embolism, which we'll go into in a subsequent section. Septal flattening in the right heart, pressure overload, and mitral valve pathology that may contribute to acute pulmonary edema. So as far as clinical relevance, the cross-sectional assessment of the heart shows us ventricular function as well as septal dynamics. For application, we're going to use the PSAX view in assessing for right ventricular overload or septal flattening, and it may be the first and only clue to a massive pulmonary embolism. And as far as utility, different PSAX levels, the aortic, mitral, papillary, and apex, allow tailored interrogation, and they're vital when time is limited. So such as in the case when you have a critical patient whose vital signs are kind of bottoming out, increased work of breathing, and you're not necessarily sure why, you can use the PSAX view to evaluate how their global cardiac function is and how their heart's functioning in relation to the rest of their body. Phew. Okay, so we are done with the parasternal long axis views, and that took a ton, right? So there were a lot of things that we wanted to see there and a lot of calculations we're doing. Now we're going to move to our PSAX, the parasternal short axis views. So we're starting in a short axis, looking at the heart from inferior to superior, and this involves tilting and sliding of the probe. Sometimes these views can be tough to understand truly where you are, so I think I like to use landmarks of whether you're at the valve, whether you're at like mitral or aortic, or whether you are in the mid-region of the ventricle or down at the papillary muscles, which can look like more hyperechoic and just larger or denser structures. So practice these a bunch. Getting to know where exactly you are from inferior to superior on the heart is a skill without a valve, and go from there. So we're going to look at the aortic plane, the mitral plane, papillary muscle plane, apical region. So starting with the mid-papillary view, we're trying to get information regarding the overall ejection fraction, how well are the valves coming together and opening back up. Looking at the right ventricle for any sort of dysfunction. Is that right ventricle bowing into the left ventricle at the interventricular septum? Is there a lack of systolic motion with the right ventricle? And then same with the left ventricle. Do you see regional wall motion abnormalities? And what I mean by regional wall motion abnormalities, say we're looking at this entire left ventricle, is one part of the left ventricle here, moving differently than the other parts of the left ventricle. And that's important because that could indicate ischemia or some other abnormality to one specific part of the heart. Think about looking at EKGs, which we'll talk about, and how those can correlate to what you're actually seeing on ultrasound. You can infarct one specific part of the heart while having normal function in the rest of it. So the structures that we're looking to identify at the PSAS mid-papillary level are the right ventricle, left ventricle, and papillary muscles, these little Goombas kind of hanging out down there. We're also looking at the wall motion, and we're not using Doppler to assess anything here because there's no valve, right, that we're looking at. Moving on to the mitral valve view. This is colloquially called the fish mouth view because you see a fish mouth opening and closing. We're looking to identify the right ventricle, left ventricle, anterior and posterior leaflets of that mitral valve. right here. Overall, the right ventricle should be a third of the size of the left ventricle. If we have changing of that, then that can be pathologic, right? So we have a buildup of, say, like pulmonary pressure if you're getting the right ventricle starting to bow out into the left ventricle, or you're getting a larger right ventricle because there might be something like a pulmonary embolism. So again, you're assessing left ventricular wall motion. Everything should thicken on systole and everything should thin on diastole. And then you also assess leaflet coaptation. So the mitral valve leaflet should be coming fully together and then moving fully apart. When you put color Doppler on this, you should be seeing a lack of color during systole. So once everything is squeezing, the mitral valve leaflet should be completely closed so that you're not getting regurgitation from the left ventricle into the left atrium. And in that, there should be no color on color Doppler. And we're not using spectral Doppler here. Moving on to the aortic view, this is traditionally called the Mercedes-Benz view. It's called the Mercedes-Benz view because we're making that Mercedes-Benz sign right here. That's showing us that we do have 3 leaflets. So we have the right coronary cusp, the left coronary cusp, and the non-coronary cusp. So in here we can kind of see the right coronary cusp, and then we're seeing the non-coronary cusp down here, and then the left coronary cusp. We want to see that those are all coming together as well. In the same way that we were looking at the mitral valve, we can put on color Doppler here to assess for coaptation abnormalities where there's blood flow in systole or diastole where there shouldn't be. You can look at the right ventricular outflow tract with Doppler to see a similar thing. And then advanced evaluations that we're not going to talk about here are bicuspid aortic valve. So if you're only seeing 2 cusps there, is that a congenital anomaly? Grading of aortic stenosis, so severity of it, is a whole other set of calculations that we won't be going over. Tricuspid regurg, and then calculating pulmonary pressures here. Moving on, we have the apex. So this is just looking at myocardial motioning and thickening are assessed. There's not a ton here, and it's I would say mostly covered when you're looking at the bulk, like the papillary levels of the left ventricle. It's something to note as well.